Okay, so pleased to present our next speaker, Dr. Ashutosh Jadhav from UPMC Stroke Institute, speaking on perfusion-based stroke treatment strategies, extend trial and beyond.
Favorite topics, which is really the relationship between time and stroke and treatment options. And I'm gonna, let's see, trying to control the slides here. Okay, so I have no relevant disclosure. So when we think about acute ischemic stroke, generally we think about this concept of a blockage occurring in a blood vessel, and downstream of that blood vessel, tissue is threatened. When there's tissue that's dead, we call that core, and when there's tissue that's at risk of becoming infarcted, we call that penumbra. And this is kind of the basic concept that drives a lot of our treatment paradigms. And as Santi alluded to, the conventional thinking is that once the core is larger than 70 cc's, there's not much significant mismatch, but less than 70 cc's, there is target tissue for us to revascularize. So this concept is probably oversimplified. We borrow it from astronomy, where the idea being that the core or the umbra is the dark shadow, and then the light shadow or tissue that's at risk is the penumbra. And I just want to sort of acknowledge that likely what we call core is not all core, and what we call penumbra is not all truly recoverable. So with that caveat, we do sort of use these concepts to drive the way we think about treatment paradigms. So generally, there's adequate cerebral blood flow. You have normal perfusion. When there's a blockage, that blood flow decreases, and you have tissue that's now hypoperfused. A portion of that tissue is now symptomatically hypoperfused, or what we call ischemia, and then there's tissue that's also hypoperfused, but perhaps not causing symptoms, and we call that oligemia. And then ischemic tissue then can be further classified into this penumbra and infarct core. So that really is the basis for how we decide who benefits from reperfusion therapy. The concept of time and reperfusion therapy has been long appreciated. This is from thrombolysis data, so from pooled analysis of alteplase receiving patients. And what we can see is that the sooner you treat someone, that is, if you treat patients within 3 hours versus 3 to 4.5 hours, or beyond 4.5 hours, there is a decrease in the odds ratio of benefit of alteplase over placebo. And these are, again, patients selected based on head CT. But another concept that we've recognized for a long time is that not all large vessel occlusion strokes are the same. And theoretically, when you have a blockage at time 0, the core is 0 cc's, and the entire MCA territory, in the case of an MCA occlusion, is at risk or penumbral. But we know just anecdotally, and you see this in your own clinical practice, this is just 2 patients that happen to have come to our center at around 2 hours. Patient 1 has a left M1 occlusion, and they underwent MRI showing 163 cc's of core on presentation, and the patient number 2 came around 2 hours with a right M1 occlusion with 7 cc's of core. So these may not be phenotypes we recognize just based on clinical exam, but when we do advanced imaging, we can see that the core size is different in these 2 patients, suggesting there's underlying differences in their pathophysiology. So this concept has been looked at in Diffuse 2. These are patients who presented at different time points, underwent MRI. You can see the sort of familiar rapid map there. And there are patients with different size cores presenting at different time points. And you get a graph like this when you plot out the different patients. And there are patients with really large cores, which we call fast progressors. That is, they progress to have a large infarct at a fast rate. And there are patients on the other side of this graph that are slow progressors. They come at late time point, but have a small core. So this concept of fast and slow progressors is one that we've increasingly appreciated. And what is the physiological basis underlying these different phenotypes? I think we use collaterals as sort of a shorthand for what these might be in terms of mechanism, why there's differences. And we tend to think of patients coming in with good collaterals as having a small core or being slow progressors. So since collaterals support the penumbra in the presence of a blockage, we say time is brain, collateral sustained brain, and then when collaterals eventually fail with time, the patients will have a large stroke. So in a sense, collaterals is brain. And again, I think one caveat I would sort of add to this is we spend a lot of our conversation about this concept around the supply side, which is the collaterals, but equally important is the demand side, which I think needs a lot more research. That is, what is the ischemic tolerance that a tissue has? So for example, you could have very moderate collaterals, but still be a slow progressor, or sometimes even poor collaterals and be a slow progressor, likely related to high ischemic tolerance. But nonetheless, we do tend to sort of think about this as a collateral-driven phenomena, at least in the way we talk about these patients. So this is a montage of patients who underwent multiphase CTA. So the concept here is that you get a CTA at time 0. After that bolus, the patient is rescanned multiple times, and then you get these multiple phases. So I think many centers do single phase CTA, but if you recall in the ESCAPE trial or ESCAPE NA1 trial, there are paradigms out there using multi-phase CTA. So this patient on the top panel here has good collaterals, and when you scan that patient at phase 1, phase 2, phase 3, you can see persistent filling of blood vessels in the tissue that's at risk past the MCA occlusion. And then the patient in the middle there has intermediate collaterals, not as robust filling at phase 2 and phase 3. And then the patient with the poor collaterals, you can say even on phase 1, really doesn't have much in the way of collateral. So we can use multi-phase CTA to help us discriminate these different phenotypes. This is a paper from Cincinnati looking at the same concept, that is that perhaps the time clock is important, but not as important as this sort of tissue clock or collateral clock. So this panel A is really what I'd like to highlight, which is that there are patients that come in with different infarct growth, and that's been sort of displayed similar to what you saw in Diffuse 2. And you can see the patients with poor collaterals tend to have fast infarct growth rates. So these are fast progressors. And then you've got the patients with good collaterals who have a very slow infarct growth rate. And this sort of, again, highlights the importance of collaterals. And although this is, again, the sort of not really the focus of this talk, but I just want to highlight in this graph also that you see patients here with poor collaterals, that is the red dots or the red lines, who still actually have a slow infarct growth rate. So again, I think this highlights that there is a second half to this equation, which is the demand portion, that there are patients with high ischemic tolerance that despite having poor collaterals may still be having a slow progressor phenotype. Okay, so we looked at this at our center. So this is work of one of my colleagues, Marcelo Roca. So he basically looked at consecutive patients with MCA occlusions who presented at different time points and had baseline imaging. And he basically classified those patients based on the size of the core and the time in which they presented. So patients who came in within 6 hours with core more than 70 cc's, he classified those as fast progressors, and patients with less than 30 cc's on presentation who presented beyond 6 hours were slow progressors. And using this definition, he is able to basically roughly estimate the frequency of fast and slow progressors. And you can see, at least in our single center analysis of this, 1 in 4 patients are fast progressors, and a little bit over half patients are slow progressors. So this sort of gives us some sense that slow progressors are probably more common than we realized prior to this analysis. So again, this is the paper that he wrote, and that demonstrates the percentages that we see at our center. And this, of course, is just a working definition to help us get a handle on who these patients are. So, when you think about how we learn about stroke and the interaction between time and tissue lost, we really kind of go back to medical school, where you learn time is brain. This has really been kind of quantified by Jeff Saver in this seminal paper, which roughly estimated that you lose about 2 million neurons per minute. And this is based on about 50 patients that had large vessel occlusions, where he had baseline infarct volume. and an average lasting well time. So this is an average of patients. And so we say on average, you lose 2 million neurons per minute. But based on this sort of appreciation that we have different sized strokes at different time points, that there is some heterogeneity in patients, we revisited this concept looking at core infarct volumes and the time at which patients presented. And using this data, we're able to sort of further refine this concept. So on average, in our data, we do see that patients lose 2 million neurons per minute, but there are extremes. So there are patients who lose more than 24 million neurons per minute, and there are patients who lose less than 15,000 neurons per minute. So there's a wide spread. And so when we think about a workflow, we are increasingly appreciating that 1 minute of time or 2 minutes of time is maybe different between patient A and patient B. So just to summarize this background here, time is a surrogate for tissue. That certainly time is still important. And as time progresses, patients lose tissue in the absence of reperfusion therapy. On average, patients lose about 2 million neurons per minute in the setting of a large vessel occlusion, but there is high individual heterogeneity, which is really the basis for why we can offer treatments at late time windows for a subset of patients. And roughly, we think about 25% of patients are slow progressors, 25% are, 25% are fast progressors, and 55% are slow progressors. And we think that this good collaterals and slow progressors give us some basis for offering reperfusion therapy in the late time window. So really, when you think about who can we treat beyond these conventional time windows, whether it's for TPA or thrombectomy, the goal really is to identify tissue at risk by some strategy, and then to understand, is there a mismatch between how much tissue has been injured versus the clinical deficit. So this is really a perfusion-based paradigm or a clinical core-based paradigm. And the methods that you can use are just CT head to measure core, or DWI, or CT perfusion. And there's debate about whether that should be blood flow or blood volume. And then how do you identify tissue at risk? And there's been several kind of approaches that have been proposed. There's perfusion imaging. There is a concept of DWI flare mismatch. And then there's just clinical deficit to identify tissue at risk. So I'll talk first about perfusion imaging. This is, again, a concept that really I think many of us are familiar with using CT perfusion, either in the early or late time window. And basically the concept is you can identify core based on some sort of aspect of perfusion imaging, whether that's relative cerebral blood flow as they use in the rapid software, or cerebral blood volume. And if you take a patient who has tissue at risk and you recanalize that patient, as in the first panel there, that is, there's a target mismatch, the TMM, with successful reperfusion, you can restore that blood flow and you can save the patient from a large stroke. And then you can see a patient with target mismatch without successful reperfusion, and you can see that patient ends up having a large core that matches roughly what the perfusion predicted. And then there's also this concept of malignant profile, that is patients who have a tissue at risk with a really high Tmax, and those patients are felt to be high risk for reperfusion injury. And really conceptually, I would argue that the malignant profile is representative of a ultra-fast progressor. So this population is likely poor collaterals, is losing neurons very quickly. And I think there's debate about whether you should do more advanced imaging to identify who these patients are that have target mismatch, or I would argue do less advanced imaging and open that patient up faster, as the penalty of time in this malignant profile population is probably even higher than in a regular patient with moderate or a slow progressor phenotype. So there are, of course, also patients who can have total mismatch, and this is kind of a rare population, but it can certainly be identified by MRI and perfusion imaging. So that is, there's no core, zero core, and tissue at risk. So this really kind of highlights how extreme we can have. So we can have ultra-fast progressors, that is what I would call the malignant profile, and there is the ultra-slow progressor, that is the patient with total mismatch. So this is kind of the spectrum of patients that we see. This here is a table of different trials that were conducted to look at the benefit of thrombolysis in patients, thrombolysis or thrombectomy in patients who present with some sort of mismatch. And these trials, you can see, were conducted over the last 10 plus years. And they all use different kind of paradigms. So there's Epithet, which used MRI diffusion perfusion mismatch, Extend, which used CT perfusion mismatch, ECAS4, which used MRI diffusion perfusion mismatch, and then the Diffuse 3 trial, which was the thrombectomy trial that used core mismatch. So these are all trials that use perfusion mismatch to identify patients who have this slow progressor or tissue at risk target mismatch. Okay, so what do we mean by target mismatch? So this is just a reminder that it's effectively, this is the sort of definition that was used for the Diffuse 3 trial, patients with core less than 70 cc's. This is really based on Albert Yu's seminal work that Santi alluded to in his talk. And these are patients that have a volume of tissue that's at risk with a ratio of 1.8 or higher relative to the tissue that's already been injured. And then there's also this definition of absolute volume of tissue that's at risk of 15 cc's or higher, and those tend to track together in most patients. Okay, so you'll be probably all very familiar with this, but this is the results of the Diffuse 3 trial where patients were randomized to thrombectomy in the 6 to 16-hour time window versus medical therapy alone. A small percentage of patients did get TPA, but majority did not. And these were, again, patients identified based on the target mismatch paradigm. And you can see there's overwhelming benefit in terms of the primary endpoint of MRS 0 to 2, that is functional independence. So this was the first positive trial of patients using the CT perfusion or MR perfusion paradigm for patient selection in the late time window. And this was with thrombectomy and not for selection for thrombolysis. For thrombolysis, there have been several trials that have been conducted. This is one of the more recent ones. This is the Extend trial, which looked at patients in the 4.5 to 9 hour time window. And this is a primary endpoint of MRS of 0 to 1. So it's a little bit milder deficit than used in Diffuse 3. Patients were eligible based on NIH of 4 to 26. And then again, this is the target mismatch definition, which is a little bit more liberal than the definition used in Diffuse 3. But again, core of less than 70 cc's and target mismatch. And a couple of highlights from this trial. So basically, the median NIH was on the lower side. In most thrombectomy trials, the median NIH is about 17. In this trial, the median NIH is a little bit lower, about 12 in the alteplase arm and 10 in the placebo arm. Many of these patients did harbor a large vessel occlusion, and this was conducted at a time when thrombectomy was not considered a standard of care. So many of these patients may not necessarily have gotten thrombectomy. You can see there is a higher rate of symptomatic hemorrhage in the patients who got TPA. There was a majority of patients were wake-up strokes, which is generally the case with these late time window trials. And then you can see that there is benefit in the patients who got alteplase that met significance for the primary endpoint of MRS of 0 to 1. So you can see the good outcomes are 35.4% versus 29.5%. And this trial did show benefit of using this paradigm in patients. And again, there's some caveats here. That is that there were many patients had large vessel occlusions. They did combine this data with other trials that looked at the late time window. Specifically, they looked again at TPA. Again, majority of these patients had a large vessel occlusion. Almost all of these patients were recruited before the late time window guidelines were published. And again, you can see there's a symptomatic hemorrhage rate that is higher in the alteplase group, but nonetheless, the primary endpoint of MRS 0 to 1 at 90 days was higher in the alteplase group versus the placebo group. So really, there is data supporting using this approach with some of these caveats. And I would say that this concept of penumbral mismatch is further examined in this meta-analysis. Here you can see that in the same data set, there's a separate publication, but they looked at patients who had target mismatch versus those who did not have a target mismatch. And you can see the benefit is there in the alteplase group and the patients who did have a target mismatch, but no benefit was demonstrated in the group that did not have a target mismatch. So really supporting the concept that you need to identify some sort of mismatch in this population to show benefit. Okay, so really that was to talk about the perfusion paradigm. The other one that we talk a lot about is this concept of DWI flare mismatch, and I will talk a little bit about the basis for that. Generally, when we think about patients with late time window stroke, you can think about them as sort of three different phenotypes. One is wake up stroke, that is a patient who went to bed normal, and then upon awakening, they were noted to have some sort of deficit. And so in theory, in that population, we don't know the exact time of onset of symptoms. Then there is the unwitnessed stroke population where the patient was last seen well at some point and then had symptoms onset that were not witnessed but these were not detected upon awakening either. So this is a second population. And then witness stroke are patients who have symptoms, they're witnessed, we know exactly when the symptoms started, but they present to reperfusion therapy options at a late time window. So these are the kind of the three populations we think about. When you think about wake up stroke and unwitnessed stroke, the one sort of consideration is that potentially these are early time window patients. So for example, it's known that in patients there is a higher risk of atrial fibrillation. There's a cortisol spike early in the morning. So patients who go to bed, for example, at 10 p.m. and at 7 a.m. are noted upon waking to have clinical deficit. Theoretically, it's possible they had an LVO formation at 6 p.m. at 6 a.m. or at 5 a.m. and that they're actually in the early time window. So in principle, in wake-up stroke or unwitnessed stroke, we have this uncertainty about when symptoms started, and can we somehow identify patients who might be actually early time window patients. So this really is the basis of the wake-up trial, which was a trial using this MRI diffusion flare mismatch paradigm. So let me just sort of walk you through that for a second. So the idea is that when you have a positive DWI lesion and a negative flare sequence, that there is a high specificity and sensitivity to suggest that the stroke onset was within 4.5 hours. So this is just some examples to kind of show you the concept here. So in panel A, you see two MRIs there of a patient with a restricted diffusion and no correlate on flare. So the idea is that that patient likely had a LVO that was within 4.5 hours, and that might be a patient with conceivably salvageable tissue, because even though they had a wake-up stroke, the stroke happened much sooner than one may have initially predicted. If you look at the patient, the two MRIs in panel B, these are examples of patients who have, again, restricted diffusion or DWI, but there is also T2 hyperintensities or flare hyperintensities in the same region, suggesting that the stroke is beyond 4.5 hours. So using this paradigm, the wake-up trial effectively tried to identify patients who are in this quote-unquote early time window based on this imaging paradigm. So the wake-up trial took patients that were either wake-up patients, as the trial's name suggests, or there was a small percentage of patients who actually came in within this early time window based on symptoms onset, and those patients were randomized to receive alteplase versus placebo. So the in this trial, there was a trend towards a higher rate of death in the patients who received alteplase, as well as a higher rate of SITCH in the patients who received alteplase. However, for the primary endpoint of favorable outcome at 90 days in this study, there was statistically significant benefit of 53.3% good outcomes in the alteplase group versus the 41.8% good outcomes in the placebo group. Again, this trial did show benefit for the primary endpoint, despite higher rates of death and hemorrhage in the treatment group. So what are the other considerations with this data set? So the investigators further looked at patients who may have had lacunar infarcts, and they again found patients who had lacunar infarcts also showed some benefit of alteplase versus placebo, and this is really kind of to address some criticisms that perhaps in the trial the benefit is really specific to medium vessel occlusions or large vessel occlusions and not broadly applicable to other types of infarcts. So based on this result, there are centers that are routinely giving TPA for patients based on this paradigm. However, to exercise some caution, this is an editorial that accompanied the paper by Tudor, and really he highlights a few things. One is that if you look at the subgroup analysis in the patients who had NIH greater than 10, there was no benefit of alteplase over a placebo. The NIH, again, was low. I mean, if you recall in Extend, the NIH was around 10 or 12. In this study, the median NIH was 6. And then the other sort of concern is that they did not really look for large vessel occlusion in all the patients. So, what is the sort of relationship between penumbral imaging in this population and the patients that would benefit from this DWI flare mismatch paradigm? So I think this is a trial that is very intriguing and certainly has changed practice locally for some centers, but I think there's still some skepticism about how applicable this is. And, I would say that a couple of the criticisms or concerns before you implement this, because certainly in our network, centers ask us whether they should start treating patients based on this. Important considerations are that you need to get an MRI, so this may not be feasible at all spoke hospitals. It's limited to patients 0 to 4.5 hours upon awakening. It only identifies this paradigm 62% of patients who are within the 0 to 4.5 hour time window. So it doesn't necessarily identify all those patients that may have target mismatch, and the benefit is really only in patients with a low NIH. Recently, and again, this is data that's been presented before, but this was recently published in Journal Stroke in Japan. A similar DWI flare mismatch paradigm was applied, and they did not see benefit using this this mismatch of DWI flare in patients who received alteplase versus placebo. So the wake-up study was positive. That was 0.9 milligrams done in Europe. And in Japan, the trial showed no benefit, but just one caveat is in Japan, they use a lower dose of TPA. They use 0.6 milligrams. And so perhaps that may explain some of the discrepancies between the two trials. But as of now, we have one trial that shows benefit and one trial that is neutral. Okay, so we talked about perfusion imaging, we talked about DWI, flare mismatch, and then finally, the third paradigm you can use is just clinical deficit. That is, you, the examiner, by doing an exam, NIH stroke scale, you are basically measuring the tissue at risk based on your clinical assessment. So this concept really dates back to this paper by Davalos in Barcelona. And what they found is if they take patients who presented within 12 hours of symptoms onset, just over half the patients actually have a clinical DWI mismatch based on just clinical exam and NIH upon presentation. So you can see in this graph, they graph NIH versus DWI, and they see that just a little bit, almost above 50% have this mismatch. And this mismatch is very high early on, so 74% within 3 hours. But interestingly, if you go to 6 to 12 hours, 46% of the patients have a clinical DWI mismatch. So just clinical exam can tell us a lot in this patient population. And this clinical DWI or clinical core mismatch paradigm was the basis for patient selection in the DAWN trial. So as you recall, in the DAWN trial, again, this was a trial comparing the Trevo stent retriever device compared to medical therapy in patients selected based on a NIH and core mismatch paradigm. About 9% of patients did get TPA in the control arm, but a majority of patients did not get TPA. So this is really largely a comparison of thrombectomy versus no TPA. And there was significant benefit for MRS 0 to 2 in this trial. And again, one of the criticisms, again, in this kind of study is that was the benefit really driven by the wake-up population? We looked at this more carefully. We divided up the patients as wake-up versus witness versus unwitnessed, and you can see here that the odds ratio of good outcome is in favor of thrombectomy across the different modes of presentation. So this is really a trial that shows benefit irrespective of how patients present and their onset, that as long as there's tissue at risk, you're better off getting thrombectomy than medical therapy. And of course, in this study, we really went up to 24 hours. In Diffuse 3, those investigators went up to 16 hours. But if there's mismatch, there's mismatch, and really nothing magical happens after 24 hours. If you still have tissue at risk at 24 hours and 1 minute, or 27 hours, or in this case, this study from NEMA in Jacksonville, they showed that they had a patient who presented and then 6 days later eventually underwent thrombectomy when the exam became worse, and they were able to achieve revascularization and clinical benefit. So this concept that really time matters probably needs to be removed from the way we think about treatment eligibility, that there really is no time limit as long as there's tissue at risk. And we've looked at this with other centers. This is a sort of multi-center study where we looked at patients who underwent thrombectomy beyond 24 hours who otherwise met Dawn criteria. And you can see the good outcomes in those patients. The small number of patients, it's about 0.6% of the population at our comprehensive stroke center. But you can see here that the good outcomes are 43% versus the 48% good outcomes in the treatment arm of Dawn. So really, time should not be an exclusion criteria if patients meet criteria otherwise for thrombectomy. So one question that always comes up is if we're treating patients and we have these number needed to treat, if you look at ECAS-3, the number needed to treat is 14. And NINDS, the number needed to treat is 10. And you can kind of see that we've become very selective, especially if we use very stringent criteria for patient selection. Extend IA, Diffuse 3, Dawn really use stringent criteria. And the number needed to treat is 3. So it really begs the question, are we being overly stringent in how we select patients? And it really depends on how you look at resource utilization. This is a meta-analysis of patients who underwent PCI. So these are patients who presented with MI, and what you can see is that the number needed to treat for MI to prevent death with primary PCI, the number needed to treat is 45. And if you think about our numbers, we're debating about whether to treat somebody, and the number needed to treat is 3 or 10 or 20 even, we're well shy of what number needed to treat you have data supporting PCI, which we routinely perform without having these kind of debates. So in terms of who's eligible for late time window thrombectomy, this is a log that we kept at our center of all patients that presented during the Dawn enrollment time period. And we basically whittled down those patients based on whether they met eligibility for Dawn versus Diffuse 3. And you can see in this Venn diagram, there are patients who meet criteria for both or meet criteria for one trial or the other. But in either case, overall, the eligibility is about 2.7% of patients. And this really kind of highlights that, especially if you're looking at patients presenting in the late time window with a large vessel occlusion, that ends up being about 1 in 3 patients. During that time period of Dawn, we also treated patients that did not necessarily meet Dawn criteria. So we took patients who were not trial eligible, and we looked at their outcomes compared to patients who were Dawn eligible or Diffuse 3 eligible. And this population, this non-Dawn, non-diffuse thrombectomy population, had good outcomes of 30%. Again, this is single center data, but if you compare that to Dawn, the good outcomes, which were 54%, or Diffuse 3, 38%, these were significantly higher than the patients who got no thrombectomy, where the good outcomes are really dismal. And these are patients who really don't get any kind of reperfusion therapy. So those good outcomes are 12%. So what this tells us is likely we can be much more stringent, much more liberal about who we treat, and that our current paradigms are trial-based and likely, as Sunil talked to you about yesterday, and as Santi alluded to, we really can't push treatments beyond the guidelines. those trials are designed to show benefit, but then we take a step back and look at it pragmatically. There's many more patients that likely benefit from reperfusion therapy. So what is the future direction here now in the late time window? Are there stronger lytics that we should be thinking about? Should we combine lytics with thrombectomy? Keep in mind that Wake Up and Extend trials were done kind of pre-thrombectomy era, so they really excluded patients who could go undergo thrombectomy. One of the areas of a lot of interest is the use of tenecteplase, which has several benefits and is a lytic that's being used more and more in cardiology in patients who cannot undergo PCI in a timely fashion. The benefits really are that it has a higher specificity for fibrin, binds plasminogen activator inhibitor 1 less avidly, so it tends to hang out a little bit more. It does not get inactivated as quickly as TPA. It is a single bolus, so if you think about this from the standpoint of drip and ship models, it's not really drip and ship, it's really bolus and ship, and these are patients that can transfer without the need of a critical care nurse or critical care team, so that can open up some flexibility. We have some centers in our network, at least, where they're very anxious about losing a patient and the pump that goes with the TPA. So with the bolus, you have that additional advantage. And again, it's being used in more and more for acute MI, where they're seeing lower risk of bleeding. And all the data so far, at least in acute ischemic stroke, suggests that it has a comparable safety and efficacy to alteplase and TPA. These are the studies that have been done to date, looking at the benefit of tenecteplase versus alteplase. And again, most of these trials have been designed really for non-inferiority, but they have all shown comparable efficacy of tenecteplase to alteplase. And just sort of one thing to think about is that one of the issues that's sort of been an open issue is exact dosing of tenecteplase, and this is something that's been debated. In the NORTEST study, they used 0.4 milligrams per kilogram. In other studies, they've used lower doses. The Extend IA TNK study did look at the two doses and found no significant difference. This was presented at ISC this year, but it was really important for us to just at least get some clarity on which dose to use. So bottom line is we can use 0.25 milligrams, which is the dose that's currently being used for the Timeless study. There are some other trials looking at the use of tenecteplase in the Wake Up population. So this is the TWIST study, which is looking at 0.25 milligrams of tenecteplase in patients who present based on just CT alone without a large core, and they're being randomized to tenecteplase versus placebo. So this is being done in Europe. I think one of the questions that really many of us are interested in is there benefit of lytics beyond just thrombectomy in the late time window? And I think this is kind of debatable because on one hand, you can argue, well, these are slow progressors. By definition, they're late time window patients that in a fast progressor population, getting a lytic on board quickly, whether it's a mobile stroke unit or at the spoke hospital, those are patients where the core is growing very fast and you want to get lytic on board as quickly as possible. But in the late time window, maybe it doesn't matter that if you save an hour, it doesn't really make a big difference. And certainly if you look at the data of spoke versus hub hospitals that were treated in Diffuse 3 or in Dawn, there was no difference in patients that were presenting to the spoke hospital or the mothership first. And that's different from the early time window studies. So on one hand, you could argue there's no real additional advantage of lytics. We really don't need additional lytics. We've got thrombectomy, which works very well. But on the flip side, I find this very interesting that if you look at the endovascular versus control arm in Hermes, which is all the early time window trials, and Diffuse 3 and Dawn late time window trials, the good outcomes in the endovascular arm are basically the same, that the patients do about 46, 47% patients do well in terms of MRS of 0 to 2. Interestingly, the control arm is much worse in patients in Dawn and Diffuse 3, and likely those are because patients did not get any kind of lytic therapy or any kind of reperfusion therapy. But the other thing that really kind of gets glossed over is that if we think about the average core size In the early time window trials, when patients initially present, it's about 25 cc's. In Dawn and Diffuse 3, the core sizes were smaller, in the order of 9 or 10 cc's. And so despite smaller core size, even the thrombectomy arm does about the same in these slow progressors, and sort of begs the question, why don't they do better? And is there things that we could be doing differently to improve this ceiling effect? So I think that the question really is open, and this is being addressed by the Timeless study, which is a late time window trial, really very similar selection criteria to Diffuse 3, patients presenting with this target mismatch going up to 24 hours. And patients who present with this target mismatch would then be randomized to receiving tenecteplase versus placebo before undergoing thrombectomy. So I think this trial is really going to help us understand whether there's an additional benefit of lytics in the late time window beyond endovascular therapy. And I think this is also going to be interesting to compare patients who come to the spoke hospital versus the hub hospital, and there may be some differences in those two groups. So how do we think about all this? And this is, I think, my last slide. So really, if you take patients who present beyond 4.5 hours, you can divide them into proximal occlusion or distal or small vessel occlusion. And patients who have a proximal occlusion who have a mismatch based on clinical core mismatch or deficit and perfusion mismatch, I think that the question of a lytic agent is still being debated. That's what the Timeless trial would help us understand. Perhaps it makes sense for patients who are with distal occlusions, like a very distal M2 occlusion that you may not want to chase. But ultimately, these are patients for the large part who would undergo thrombectomy at most centers, irrespective of time, as long as there's target mismatch. Patients who have a distal or small vessel occlusion who come and present with a mismatch based on a target mismatch that was used in the Extend study, those are patients that could conceivably receive lytics. And again, they tend to be lower NIH about 10 to 12. And again, remember in Extend, about 70% of patients did have a large vessel occlusion, so this may not be applicable to most patients. And then patients who have a wake up within 4.5 hours, if there's a DWI flare mismatch, should we be giving alteplase? Wake up would suggest we should. Thaws would suggest we shouldn't. And I think this is still a matter of debate and prone to local practice. And then I think the TWIST trial will be important in helping us resolve this question, particularly for patients who can't get endovascular therapy. So I think this is my last slide. I'm going to stop here and take any questions if there are any.
I have a few questions. In countries where CTP isn't readily available, or circumstances where the machinery isn't working, under what circumstances would you use DSA capillary phase as a CTP substitute? Are there clinical criteria that you would just take the patient to angio?
Right. So, I mean, if I understand the question correctly, I think that this issue of treating patients in the late time window is sort of running up against local resources and access to advanced imaging. And really, again, just to emphasize points that were made earlier, that the late time window trials were designed very sort of rigorously to identify the perfect patient. And certainly we proved our point that you can treat patients at a late time window safely. But I think that selection criteria was overly rigorous. And, we've looked at this recently, that there is a very high concordance between aspects and tissue at risk, even at late time windows. And so we really use CT quite a bit as well. I don't think that if someone presents in the late time window, you need a CTP or DWI. And, kind of just from my standpoint, if you trust a CT at 2 hours to give 90 milligrams of systemic thrombolysis, I'm not sure why you wouldn't trust a CT at 16 hours to do a thrombectomy. So I think that this issue is still, some centers are kind of hung up on this. I don't really think it's terribly important. I mean, obviously, if you have advanced imaging, it's great. If you don't have advanced imaging, I do think CT is adequate, and we're probably hurting more people by overthinking it than helping by being overly selective.
Another question came up about the dosing of TPA. What clinical scenarios do you think low-dose TPA might be appropriate, if any?
Right. So there is some data that the TPA complication rate for symptomatic hemorrhage is higher in Asian populations, and there's been a trial looking at this. Enchanted study looked at zero point 0.6 versus zero point 0.9 milligrams of TPA, and there was really no significant difference, although the NIH was on the lower side. So I think in patients that are high risk for hemorrhage, based on the demographics, um, 0.6 milligrams seems to be adequate. Uh, I haven't practiced in that kind of environment, so we use zero point 0.9 milligrams. Um, but in Japan and in Asia, they use 0.6 pretty routinely. And there's also some consideration to the way the vials are prepared and distributed. So I think there's some cost aspect to this as well. But at least in North America and Europe, most centers use 0.9 milligrams, and I'm not sure uh, adjusting the dose makes a lot of sense unless you're in one of the Asian countries.
What's the latest regarding neuroprotection for preventing some of these fast progressors, especially in patients that are not coming directly up from the ED, transferring from another center?
Right. I mean, so I think that this real $1 million question, or sort of the magic bullet here is how do we all. So 1 in 4 of us on this call right now are fast progressors. We don't know who we are, and we'd all want to be slow progressors in this regard. So how do you turn a fast progressor into a slow progressor? I think that a lot of the neuroprotectant trials are trying to get at this issue. So really, you have 2 options. You somehow increase the supply, or you decrease the demand. So there are some paradigms trying to increase the supply. So can you do some kind of blood pressure augmentation, or does the sphenopalatine ganglion stimulation? Can you increase collaterals when those patients are being transferred? So I think that would be an interesting population to look at SPG stimulation. And then the second option, which is of a lot of interest, is can you reduce the demand? So, I think one topic that keeps cropping up is hypothermia. Should we cool patients at the spoke hospital en route to the hub hospital, and then recanalize those patients and putting them in some kind of low demand state? And perhaps some of these neuroprotectants will also look at reducing demand somehow. The ESCAPE NA1 trial was recently reported, but that was again in patients who were getting almost simultaneous recanalization. So I think the Frontier study will be interesting because that's a Canadian pre-hospital study where they're giving NA1 in the pre-hospital setting. As you know, FastMag was a neutral study, did not show benefit. So I think this is one of those questions where we really need to think a little bit more about supply and demand. I think a lot of these conversations get muddled up with collaterals, but that's just half the equation. So when we think about how do we convert a fast progressor to a slow progressor, I think we need to separate out which treatments are we targeting demand and which ones are we targeting supply.
Thank you. One question came up, any thoughts of using low-dose TPA if the patient's on warfarin and the INR is borderline, say 1.8?
Yeah, so I mean, again, I don't. Recently, I saw there's a recent publication where people are reversing NOACs and then giving TPA. I mean, I think there's all kinds of things you can do. I don't personally think it makes a lot of sense. I think it's a very expensive way to do this, and certainly you can push the limits of who you can give TPA to. It's especially patients with thrombectomy eligible. I think the answer is pretty simple. I would avoid any kind of additional lytics, especially if there's a coagulopathy. And then in terms of these borderline questions, giving kind of a half dose TPA, I'm just not sure it makes a lot of sense. If someone's already got an INR of 1.8, it makes you worried about what's going on. Do they have a clot that's somehow very refractory? Do they have endocarditis? Is it something that is intrinsic to that vessel? But I'm not sure the solution is just adding more lytics. So I personally don't do that. I'm guessing there are places that consider it, but it doesn't make a lot of sense to me. And I suspect that if there's an LVO or a blockage to chase after, that's what most centers are doing.
Some questions have come up about how to differentiate fast progressors from slow progressors prior to doing imaging, difference in demographics or other characteristics.
Yeah, so that's a good question. This is something that we're looking at very closely. We're trying to actually, we have what we think is a decent fast progressor score, which is a combination of the NIH and the aspects, which is intuitive that if you think about patients who are fast progressors tend to have a high NIH and potentially poor aspects. And on the flip side, you can think about these low NIH patients that Santi talked about. Should you treat them, not treat them? So if you have an M1 occlusion and your NIH is 2, I would say by definition, you're an ultra slow progressor, that you have a blockage, you're burning neurons at a very low rate, if at all. And the NIH tells you a lot about how much tissue has already been injured. So I would say that NIH is a very good one, that high NIH tends to correlate pretty well with the fast progressor phenotype, and low NIH tends to correlate with the slow progressor phenotype. And I think one of the issues that comes up, and this is something, with these low NIH trials, I've been personally very interested, is that we know just anecdotally that there are patients who present with the low NIH, and that a subset of patients, they do just fine. You don't need to do a thrombectomy, and they either recanalize or they have very good collaterals or very low demand, and those patients can get by without any kind of reperfusion therapy. And then there's a population that quickly crumps. They're very hypertensive. They have a positive heads-up test. They have tissue at risk. And then there's a third population that crumps in a delayed fashion, that is sort of rescue thrombectomy population. And when you think about low NIH trials, I think it's going to be hard to show benefit. I think we're going to have to enroll a lot of patients. But one thing that I think it'd be interesting to do and consider is to give them all TPA up front and wait an hour, because they're by definition slow progressors. So there's no reason you need to rush these patients to the cath lab. And I think that if they have a low NIH, they likely have very good collaterals or low demand, and you could probably give them all TPA very safely, assuming their aspects are good. So if I think these low NIH trials, the way I would sort of think about designing it is, you take all these M1s, you give them all TPA, wait an hour, and if they didn't recanalize, then you randomize them to thrombectomy versus no thrombectomy. But I think many of the trials are just taking patients on presentation, and I think we're going to get a mixed bag of who needs rescue and who doesn't. So, I think the NIH is a strong predictor of progressor phenotype.
Yeah. So some questions about TNK. There's very few centers in the United States that have been able to successfully convert over despite the safety, efficacy, and cost arguments. So what advice would you give to clinicians and to their pharmacy and therapeutics committees to push that through?
Yeah, I think this is something that many of us are grappling with. The best data for this is now that I know of, at least, is from Steve Warwick at UT Austin. He's now has 100 patients that he's treated with tenecteplase. Very good safety profile. He presented his first 50 patients at ISC. There's about $3,000 of savings per a patient. Very good safety profile. I think he had one bleed and one patient who got the wrong dose. So certainly you need good buy-in from nursing and pharmacy to do this. We're trying to do this in our network. We have not fully implemented it. We're starting with centers that already have tenecteplase on formulary for MI. So I think that creates less of a barrier in terms of getting it through your committees if it's already available in the ED. In the UT Austin experience, they're not really doing anything very different in terms of consent. If you think about it, we give TPA 3 to 4.5 hour time window every day, and that's not FDA approved. We're giving it off-label. So there should be no difference with tenecteplase. It's off-label, but there's good safety data. There is a pretty decent recommendation from AHA. There's a meta-analysis from Jeff Saver looking at those 5 tenecteplase trials. And so I think that we have good data supporting using it. But it is going to take a little bit of a climb But I think the cost savings, the shorter door in, door out time, which is what he showed in his data set, and just the logistics of transferring these patients without a pump and that single bolus, it's going to take some effort, but I would say that UT Austin data really helps the argument. Cost savings really helps the argument, but it does take a lot of coordination with pharmacy and ED staff. So I would start by getting kind of the stakeholders on a call together, share the data that's out there already, which there's quite a bit, and then see what the barriers are. But I think especially with MI, and some places are using tenecteplase for PE and DVT as well. So I think that that's a place to start, is to see what other indications are being used for with TNK.
Do you know any centers that are using intra-arterial TNK? And if so, what would be the dose or protocols?
That's a good question. There's a choice trial, which is actually TPA for distal occlusions, intra-arterial TPA. There's been a few trials that are being proposed for IA TNK. In terms of the dose, people are just kind of prorating it based on what they give for TPA. So if the systemic dose for TPA is 90 milligrams at max, and you're giving, either 1/3 of that or less intra-arterially. I don't give a lot of intra-arterial TPA personally, but based on IMS3, there are various doses out there, 10 to 20 milligrams. So I would say prorate it based on that, and certainly places are trying it, but there's not great data supporting this right now.
Okay. I think we have time for maybe one more question. In patients who have a high likelihood of getting stented, but who are also TPA candidates, do you avoid TPA due to the need of giving a dual antiplatelet load at some point in the near future?
Yeah, so with tandem lesions, I think there's a lot of debate about the best approach in terms of periprocedural anticoagulation and antiplatelets, and it's largely unresolved. I think a lot of people have local practices. So if I see a patient who's TPA eligible, I always give TPA. I don't really consider whether it's tandem or not a tandem, et cetera. I mean, I recognize that there's going to be low recanalization rates in these cardiac occlusions, but keep in mind that if you have a tandem, you may have an M2 and the M2 recanalizes even though your extracranial lesion doesn't. So that may buy you a little extra time. So I always give TPA. If I do give TPA, the only thing I do differently is when I give periprocedural integralin, which is what I use, I give a half dose as opposed to the full dose. Again, without real good data, but generally when I do tandems, they get, I take out the intracranial occlusion first, and then if there's residual stenosis, I'll give intravenous integralin weight-based, and then I put down a stent, and then they get aspirin Plavix load via NG tube in the procedure room afterwards. And so all that's the same. And if they got TPA, the only difference is I give half dose integralin.
Okay. Thank you very much.
Great. Thank you.
Thanks for a great talk and great question answer session.